Transforming Primary Care webpage. And you can sign up to future webinars, which I hope you'll do after today, on the same website. So if we could just move on the slides to the first slide, please. So the London General Practice Access web guide. I hope many of your practices may have received one of these, a hard copy in the post. But what is it? It's basically, there are 2 documents. Oh, is somebody else saying that they can't hear? So I can just see in the chat that somebody can't hear. Can I check if there's a problem with the sound with somebody else? Can somebody else put in the chat if they can hear or they can't hear? Oh, so someone else is saying they can hear. So I'm presuming we're all right. Yep, a few people. Yeah, great. Okay, fine. Sorry, somebody's obviously got their volume off just to throw me. Yes, right. The London General Practice Access Guide. Well, there are 2 documents. One is the guide, and if you manage to catch the short film, the guide's a kind of shorter version. It's got the key messages in, and it's really for you to get an overview of the content, to work with everybody in the team to decide on what are the areas that you would like to focus on. And then the manual has got much more detail and a lot more resources, so people wanting to lead on the access projects and access work in the practice may want to refer to the manual. I wouldn't suggest you read any of them from front cover to end cover, but that you dip in and out. So why did we produce the London Access Guide and Manual? Well, we felt that there wasn't a comprehensive guide. There were lots of different things, and we found that as we started to pull resources together, there were a huge number of resources in lots of different places. So we hope by bringing all of that together, that's going to be useful for people. And who developed it? So the work has been led by the Healthy London Partnership Transforming Primary Care team, but we had a great task and finish group, most of whom you will hear speaking in the webinars either today or over the next few weeks, but included working GPs, people involved in commissioning, the Royal College of GPs, Minal from the National Digital First team. So lots of people, and you're going to meet them as we go forward. So yeah, we were very lucky to have that team, and I just wanted to kind of stop for a moment and say thank you to the HLP team as well. So particularly Atia, David, Maria and Sultana, who've supported all of this work on the way through, and it wouldn't have happened without them. So thank you to them, who've done a huge amount of work for it. So who's it for? It's for everybody in the general practice team. So if we could move on to the next slide, please. So what are the aims of the General Practice Access Guide and Manual? We want to highlight a sort of whole system approach to achieving the best possible general practice access within our available resources. So I'll come to the whole system approach in a minute, but I think the available resources is really important. It's not the sky's the limit. We have to work with what we've got, and the guide is really about trying to make the best of what we can in what is, we recognise, a very difficult and challenging environment. We want and hope throughout the guide that we signpost to solutions that address inequalities. As people working in London general practice, we are all very aware of the wide inequalities we see for our patients, particularly highlighted during the pandemic over the last year or so. So we hope this is a thread throughout the guide. And we really want to do this by sharing good practice and effective access innovations and making sure a lot of this is based on evidence and good practice. So these are the aims of the guide and the manual. If we could go down to the next slide, please. So yes, achieving access is really hard. We all know this. If it was easy, we would all be seeing our patients when they wanted us in the way that they wanted to be seen and as quickly as they wanted to. But it's difficult. It's difficult in general practice. We have lots of competing demands on our time. And so it's challenging. And we hope the guide and manual goes some way to make this a little bit easier and smoother for practices. If we could go to the next slide, please. So we talk about a whole system approach. Now, I draw on the Anna Karenina principle. Now, the Anna Karenina book starts with this line, which is all happy families are alike, and each unhappy family is unhappy in its own way. And from this is derived the Anna Karenina principle. And this states that a deficiency of any one of a number of factors dooms an endeavour to failure. And consequently, a successful endeavour, subject to this principle, is one for which every possible deficiency has been avoided. So if we think about the happy family example, a happy family will have certain characteristics. So they will have a good home, they will have heating that works, they will have an income and good health and good communication skills. And there will be sort of maybe 10 things or 10 attributes of a happy family. And if you take any one of those 10 attributes away, the family will be unhappy. But each unhappy family is missing a different one of those attributes. And I think this is, we can really draw parallels with this, with providing good access for our patients. So if we go on to the next slide, please. Now, this is the kind of basis of the whole slide, this idea that there's lots of different component parts that you need to have in place. You need this whole system approach to really deliver good access for your patients. And, you know, we're all human, our practices work in difficult circumstances, but I would guarantee that most of you on this call can say, actually, we're really good at this part of it, or we're really good at this part of it, but this is an area of challenge for us. And so this is where we hope the kind of interactive guide and manual will help, that you can dip in and out and say, is this somewhere that we want to work? Is this somewhere that we'd like to improve? And both the guide and the manual include in the kind of appendix at the end a number of suggestions of quality improvement programs or projects that you might want to do, and they're aligned to each of the components of this whole system approach. And as we go through the webinars, we're going to talk you through each section of the guide. So today we're going to look at the overview and the general practice activity section, and then next week looking at working with patients. The following week, how to have the right recruit and retain the right team and support them to deliver good access. Week 4, we'll be looking at access beyond the practice, recognising that the general practice works within a wider health, social care and societal system, and how do we work with teams beyond, both to support our patients to use other services and for other services to direct patients appropriately to us. And then our final week, on week 5, we're going to look at methods of making change. So all the suggestions of things that we might want to do, how do you actually make those changes in your practice? So that's what we've included for the whole system approach. I'm sure there are things that you might think are missing, or that that you've, you know, but this is what we kind of collectively came up with as the kind of key components to a good access system. If we could go on to the next slide, please. So I'm going to now hand over to Maria Rodriguez. Maria is a senior program manager in the Transforming Primary Care team, and she's going to put the sort of access guide into context with the sort of regional and national pictures around access. So I'm going to turn my camera off and mute myself and hand you over to Maria.
Good evening, everyone, and thank you for joining us for the Access Guide webinar. So by background, I used to work in general practice as a practice manager, and I've got experience in working in primary care contracting, commissioning, and more recently on primary care transformation, specifically to do with PCN development. So I've been asked to give a bit of context on the access from a national perspective, and slightly about from a local perspective as well. Could I have the next slide, please? So some of you will recognize these key documents that have been published by NHS England. It's all started with the plans outlined within the long-term plan, which references primary care access quite a bit, and there's a lot about digital access and the ambitions in achieving a wider digital portfolio. And given with everything that happened with the pandemic, we've made quite a leeway into digital access for patients across various services. But more relevantly, I think for general practice is the detail within the update to the GP contract agreement, which was recently updated in February 2020, provides a bit more detail about how access is seen from a national perspective. And then from a London perspective, we've published a couple of documents. The first was the strategic commissioning framework, and a follow-up document was the next steps to the strategic commissioning framework. And this document outlines the ambitions for access, precisely proactive access. So it's a good read if you haven't had a chance to read it as yet. Next slide, please. So the large vision or the strategy for access is largely to aim for that little green dot in the middle of the Venn diagram in front of you. So it's about seeing patients at the right time, in the right place, and by the right healthcare professional. And with the addition of the new roles that have come in as part of the PCN working, there are various professionals that can take away from the GP quite a bit of workload and see patients by different other healthcare professionals that have just been introduced last year and this year. Next slide, please. So just a bit more detail about what's within the GP contract to do with access. So the government made a commitment of increasing appointments by 50 million by 23-24. So that may seem quite a large amount of appointments, but it is over the span of 5 years. And this is largely achievable by the additional roles that is being funded for the PCN network, for the primary care networks. So we're expecting 26,000 additional roles to come into play by then and will contribute to this 50 million appointment. NHS England conducted an access review just before the pandemic, and the 6 bullet points or 5 bullet points outlined there are largely what came out of the access review. So there was a commitment to improve the quality of data. And if you're from general practice, you'll notice that on your clinical systems, you've got the GPAD data, which is GP appointment data. So work has begun on collecting data. There's a long way to go on improving the quality of the data, but it is a start and it helps demonstrate the value of general practice. Alongside that, NHS England has been piloting a new measure for patient experience, which is a real-time measure. So patients who attend an appointment will be sent a text and asked about what the experience was like for that appointment. So that is being piloted, and although the plans for releasing this have been delayed due to the pandemic, we are expecting it to be released sometime in the next year. Working with PCN, so as part of the access review, NHS England developed a program called the Access Improvement Program. So this has been rolled out to all the CCGs, and any practice that is struggling with access can approach their CCG and ask to be part of this program. So it's a nationally funded program. You don't have to pay anything for it, and it will support general practice in whatever actions you want to improve within your practice. So it can be related to access. It may not be related to access, but it definitely is a good resource to have if you are struggling. Digital first services, so this I've spoken about, it is progressing quite well since the pandemic. You know, there are loads of modes of appointments or contacts that patients have access to now compared to pre-pandemic. Extended access services, I'll talk about this when we get to the next slide, but also part of the vision is to have a fuller joined up system with urgent care, so linking in the extended access services, co-hours, with any urgent care services such as 111, UTCs, and out-of-hours services. Next slide, please. So I suppose the plans that affect general practice the most, that are scheduled to come into play from April 2022, are the merging of the extended hours access DES with the CCG commissioned extended access service. So these are the services that are provided by the extended access hubs, which are mostly in most areas are provided by local federations. So this is plans have been put together to merge this into a single combined offer that will be provided by PCNs. So the schedule for release of the details of what will be included with this specification is the end of this month, with the service going live from April. We know that NHS England is currently in negotiations with the GPC on this, so once those negotiations are complete, we'll hear about the outcome for it. But this is probably what will affect general practice and PCNs the most out of what's coming in the contract. Next slide, please. So I just added this slide because when creating the access guide, we're very conscious that we know what the national picture is, but what affects general practice is basically how does access feel to you and your patients. So with the guide, we aimed to improve job satisfaction, create happier, motivated teams, improve patient satisfaction, create a work-life balance, and and make sure that you have better use of your resources and you're able to manage your demand. Next slide, please. So that's all from me. I'm going to hand over to Tom, who's going to be talking to you about measuring your activity. Thank you.
Thanks, Mira. That was really helpful. Yes, so I'd like to introduce Tom. Tom, that was really helpful. Even though I was GP access lead, I always found it really difficult to keep on top of all the national things happening. So to capture those on a couple of slides, and just to let you know, all the slides will be saved on the HLP website. So when in 2 weeks' time you can't remember what the national things are, you can go there and Maria's slides will be really helpful. I'm going to hand over to Tom. Tom and I worked together many years ago in Tower Hamlets, and Tom has been one of the clinical leads in the EQUIP Quality Improvement Programme in East London, which has used data and QI methods to improve access across East London, and was shortlisted for an HSJ award last year, if I'm not mistaken. And if I am, I'm sorry, but no, I'm sure you were. I will hand over to you, Tom.
Thanks, Sean. Thank you. So I'm covering the measurement part. So I think it's one of these things. I guess the question is kind of why do we measure stuff, and why is it important to measure it in the context of access? And I sort of want to make a play for this being a really sort of critical foundation stone of really starting to understand access and trying to improve it. Maria referenced the GP appointments data work that Giash is going to talk about after me, and I think that again that's one of these really important foundation elements to starting on the right foot with improving access. Lee, can you give me the next slide, please? So why is it important to measure access? I think Maria's touched on some of the sort of national priorities. So essentially, it's kind of difficult to make a case for greater investment in primary care if we can't sort of count what we do or measure what we do, and also to try and articulate some of the pressures that are that primary care is under. So we are constantly bombarded with things like A&E data and hospital waiting times data, but actually primary care appointment data is pretty hard to come by, although we all know that the pressures on the primary care are under are absolutely immense at the moment. It's often quite difficult to articulate how busy people are in primary care, and I think that doesn't do us a great service in terms of getting the kind of funding and investment that we need to deliver the services that we do. From a PCM perspective, I think this is going to become, I think, a much more important thing over the next couple of years based on what Maria was just saying. But I think in terms of service design, identifying groups who are potentially excluded and are not accessing the care they need, trying to kind of prioritise services and plan strategically. I think it's going to be getting access to good quality activity data is going to be really essential for that. And at a practice level, you just can't start to look at capacity and demand unless you're measuring something, and so you won't understand your current position, you won't understand how things are going at the moment, and certainly unless you're measuring things consistently, you're not going to be able to understand whether any changes that you make to your appointment system are actually an improvement. Lee, if you could just give me the next slide. So I think really three basic questions here I put on the in the presentation. One to say actually we should on an everyday level be able to answer the question, how busy are we, and is this more or less than busy than we expected to be today on this day on this particular day of the year based on data that we've got from previous years. We need to know who's accessing care, and probably quite as important, who isn't accessing care. And certainly we've seen a shift in the kind of people accessing care through the pandemic, and things like online consultations have certainly appeared to be offering advantages to certain cohorts of the population. But we need to know if it's disadvantaging other cohorts of the population or other demographics. And then I think the final thing here is, are we doing the right work? So everybody's super busy, but actually, are we busy doing the right things? And I think you can't answer these kind of questions without the data. And I always think that there's access is a technical thing. It's a kind of nuts and bolts. How much of what of each thing are we offering, and when? But actually, access is really emotional and psychological, because I think we've all been experienced a horrendously busy day, and actually that the stress that puts upon people, both from a kind of clinicians and GPs perspective. Who's on nursing teams, but also our frontline patient assistants and administrative teams, who are often the people who are kind of operating the processes of accessing our systems. And what you tend to find, and we all know that when you're under a lot of stress, it's hard to it really impacts your ability to make good decisions. And I think having good quality data and using it and reviewing it regularly is a better way to inform decision making than sort of making decisions under stress without the access to the data that you need. Have the next slide for me. No. So this is just an extract from the access guide. So we do some definitions here around what we mean by need, demand, supply, capacity, because all of these are the sort of building blocks you need to be able to understand what's happening through the flow through the system. But through the work we've done with multiple teams looking at access, I think we've managed to sort of bust a few myths along the way, and certainly when we speak to practice teams, there's often the questions come up around, demand is infinite, so if we just offer more capacity, it'll always just get filled. And we absolutely know that that's not the case. Demand is high, but it's it's not infinite, and it's actually very predictable. And systems that have been operating, for example, triage models for a long period of time, are usually able to predict the demand that's going to come in by day of the week and by day of the year in a really accurate way. And that's such a fantastic asset to be able to plan your capacity. Because what we also noticed is that really probably the thing that causes the biggest fluctuations and some of the biggest challenges in access is changes in capacity. So planning around meetings and leave and making assumptions about who's going to be in the building or working virtually at what particular time, and things like working patterns are probably one of the most important things that are going to contribute to your system of access working well or not working well. And in fact, this probably has much more of an impact than any kind of fluctuations in demand beyond what you would expect them to be. Next slide, please. So just thought we'd start with some sort of basic uses of the data. So if you're just looking at your own practice data, you would certainly see some patterns emerging. So we would generally predict that most practices busier on Monday, then Tuesday, Wednesday and Thursday, your quieter days, and then sort of things picking up on Friday. And this kind of pattern seems to be true almost in every practice that I've looked at the data for, which is more than is probably healthy for any one particular person. And we also know that the demand shows some quite clear seasonal variation. So we know that winter is busy, but actually around my neck of the woods, East London, I think it's true in other parts of the country where I've had a look, is that spring is also a very, very busy period as well. And we're just kind of coming off that sort of summer slight drop, although this summer has been quite busy still, but then kind of moving into that winter period. So what we look at on this chart is the control limits, so the green lines on the bottom chart, and you can see there's quite a wide level of confidence there between what you would expect on any particular day of the year. But when you drill into the individual days of the year, you can usually predict what your activity is going to be, notwithstanding a pandemic, I might add, which is a kind of special cause variation that we're having to adapt to. But normally the patterns are quite predictable by day of the year. Next slide, please. So in terms of what you need to do as a practice if you're going to get started on this journey, first thing to do is we say sort of step one in matching need, capacity and demand is to kind of measure things. So we would start with mapping the process, essentially from patient expressing needs to that need being met. And that's a really good thing to do with your full practice team, and ideally with some patients either virtually or with you in the room, and map what happens. What are the main steps through from that expression of need through to that person getting their need being met. And then you can pretty much sort of add the data you need from that particular perspective. You need to grab some important data, so you need to know the number of appointments that have been booked, the time it's taking for those appointments. That's really critical, because the time allotted isn't often the time taken. As we all know, that kind of sort of 10-minute strange thing that we've got ourselves into in general practice doesn't generally represent accurately the amount of work that's being done. And then you also want to try and capture some measure of unmet needs. So if you want to really know what's going on in your system, you need to know about the work you're doing, but you also need to know about the people that you're turning away. So these are the people who are contacting you for an appointment or for something that they need, and they're being asked to kind of call back later or come back the next day or go somewhere else. So those are the three really critical bits of data you need to start making good decisions. Giash, who's talking after me, will talk around the appointment slots and configurations. but it's also really critical that you're using the consistent consultation modes. So when you're entering a consultation into EMIS or whatever system that you're using, making sure that as a team you're using the same kind of consultation codes. So the one that we never ever see in the data that I look at is face-to-face consultation, because you know, it's a lot of work that we do. Telephone consultations seem to be quite well coded, but face-to-face ones are a bit of a mystery, and it's so important that we're consistently capturing these kind of things. So appointment slot types are important, but consultation modes are really, really important, and making sure as a team you agree which ones you're using for which kinds of work, because that will do you lots of favors later on. Then essentially, once you've got your key bits of data, you want to look at it through the week, you want to look at it through the year, you want to look at some historical bits and bobs as well. And then from that point, you can start to do your planning. You can look at your team and start to plan where to deploy people on which days of the week, at what time, and looking at the times of the year, and then think about how you're planning your team's capacity around planned work, where you're kind of inviting patients in, or you're doing work as a practice team, for example, and how much capacity you're freeing up for reactive work. So the stuff that's coming through the door that you're having to respond to on a day-to-day basis. And so the real trick with capacity and demand is trying to kind of match those two things. So understanding what's coming through the door, and then kind of placing your capacity where it needs to be through the day and through the week. And then I think once teams have got into the flow of doing this kind of thing, actually the next areas that people tend to look at then are, well, actually, are we doing the right work? So of all the work that's coming through, you know, what does really absolutely have to see us, and which work can be done by another person or service, or by the patient or citizen themselves. And that will be referred to a bit later in the presentations today. And then finally, number 7 is just keeping things under regular review. That's the most important thing. You can't just do this once and expect it to be right for forever. It does require constant review and refining, because there's no system of access that's absolutely perfect. So we're constantly having to kind of tweak and adapt things based on our team skill mix and also the needs of the patients who are trying to access our services. Next slide, please. And then just the final thing for me looking at the data is we've been collecting this kind of activity data for a long time in Tower Hamlets and across the 3 boroughs of Waltham Forest and Newham, and now across North East London. And we're able to start using primary care data to answer some of the more kind of really sort of nutty problems and tricky problems. So just the example on the left here in the purple is trying to understand what happens to individual patients and how they flow through the system of triage. And you know, I think what you can see there is it's really complex, and it's something that really requires some time to really understand what's going on, because what you think is happening in terms of patient flow through your system isn't often the case. And you can see that there's lots of areas here where we might be processing individual patients way too much to just get a particular result. But that's what the kind of thing you can do when you can dig into the data in a bit more detail. And on the right hand side here in the yellow, we were looking at a piece of work just to try and understand the impact of switching off online consultations at the weekends, because practices were telling us that they were really struggling to keep up with that demand, and we're saying, well, you know, we're going to try and switch it off, the online consultation. So our response is to say, well, okay, let's try and understand the impact of that on your overall demand, both in practice but also in other settings. So we looked at urgent treatment centre data, 111 data, looked at groups of practice data and people who were switching things, the online consultations off, and practices who were leaving the online consultations on. And we were able to then really describe back to the system more widely, actually these are the impacts you can expect to see by turning things on and off at a system level. So really just to summarise, I would say that the kind of measurement side of things is essential just at an individual practice level, just to kind of understand your system, understand the effect of changes in your system, but really the potential of it to understand changes in a complex system are really kind of endless, actually. So I hope I've given you a view there of some of the opportunities for you.
Thank you, Tom. That was really, really helpful. I mean, it was a real rapid run through of something which is quite complex and is quite hard work. And I noticed one of the comments in the chat is about how do we find time for this? And I think you're right. It is complex, and I think it's something that's difficult to do at an individual practice level. And I think so. Some of the learning in East London is been about doing that collectively across an area or across a patch, and recognising the investments that's needed to do that. We're now going to move on to Giash, who's going to talk to us about mapping appointments. Now, Giash was a project manager at NHS Digital, and Giash and I and the Task and Finish group have had lots of conversations about general practice data and how difficult it is and how we can't measure our activity. And I take my hat off to Giash, because when he was trying to work it out, he went in to hit a few local practices to really, really understand how practices worked and how practices thought. And that really helped feed in to some of the solutions that have come up nationally. And Giash was really involved in some of those solutions. So I'm really pleased that one, was part of the Task and Finish group, because that was massively helpful, but two, can talk us through appointment mapping and national requirements. So thank you, Giash. I'm going to hand over to you now.
Great. Thank you, Sean. Hello, everyone. So just I'll briefly introduce myself. My name is Giash Ahmed. I'm project manager for NHS Digital, and I've been working on this GP appointments data since 2018. And my role really sort of has been to kind of go in to practices and sort of conduct some user research, really trying to sort of understand how they use the systems and what behavior drives the way they kind of use the systems, how that has an effect on the data quality and what we can do to improve the data quality. And as such, as part of that work, we kind of moved on to the national categories and the fact that we're now asking you to map your existing slot types. So if we go to the next slide, please. Thank you. Okay, so just to kind of give you a bit of background. So NHS Digital have been publishing GP appointments data since 2018. And back in 2018, that data was published at the CCG level. So that was primarily aimed at giving CCG's data to kind of better understand winter pressures and plan the flu vaccinations. So further to that, NHS England kind of realised that there was some value in the data, and data was actually useful for them and for us, and there was a decision made that we should now publish the data based on practice level. So trying to do it on a practice level brings in problems of itself. So if we could just move to the next slide, please. So if we kind of think about it from a practice level, all practices work differently. It's hugely varied in terms of how people use the systems, again, in terms of the behavior that kind of drives them to use the system in a way that kind of fits their needs, and it doesn't quite always sort of collate to what we want from a national requirement. So when we actually looked into the appointment slot types, we recognized that there's actually 400,000 different unique slot type names. And there wasn't really any sort of logical way of us to kind of look at data and make it available nationally to kind of consistently compare that data. So when we had those conversations with the practices, particularly GPs and the practice managers, there was a sort of like inherent need to have some kind of standardization as a way to kind of manage this huge array of slot types and appointments. And that kind of led us on to developing the national categories for GP appointments data. So if we move on to the next slide, please. So we kind of talk about the national categories for GP appointments data as a way to kind of provide or publish data that's nationally consistent, so we can kind of compare practices. So what that enables for practice PCNs and CCGs to do is to get a better understanding of their data at a local level, so they can kind of manage the resources, better plan for capacity and so forth. From a healthcare policy point of view, it enables us to look at the appointments data to help us kind of support decisions in commissioning and improving healthcare provisions. So next slide, please. So I've listed quite a lot of values here, and I'm not going to read through all of them, but what I was trying to kind of show here is that, by doing this piece of work, there's value in each part. There's value in the practice level, there's value from the local perspective, and there's value from the national. So from a practice perspective, it gives you the ability to kind of better understand your data. So if you can understand your data, you can kind of work out in terms of what the pressure points are, how you plan your resources and try to manage the demand that you have. Locally, it kind of gives CCGs and other people an idea of the demands and pressures, both in general practice and within hospitals. It kind of gives you an idea in terms of what services you need to provide, what resources are lacking, what resources are needed, and it kind of gives you some ideas around how to optimize the use of ARS roles for PCNs and so forth. And actually what it just gives us is, what it tells us is the sheer demand in primary care. You know, from the primary care perspective, naturally people kind of tend to think about, you know, GPs just provide appointments. What we've been able to show with this national categories is that, you know, general practices do not just provide appointments. They do other stuff for patients when patients are not there. They do a lot of other stuff, that are admin activities, you know, work for practices, work for CCGs, work for PCNs. So, you know, it's just not providing appointments. There's other stuff, bits of work that they need to do to kind of, you know, enable or ensure that the practice kind of manages itself as a business. So next slide, please. So I'm just going to, before I kind of move on to how you map, it's important to mention that the national categories have now been mandated by NHS England as a standard. So NHS England have recognised the value of this, and now they've decided that they're going to provide funding for this, and there's 27 points attached to this target, and NHS England will release, if they haven't already, in terms of how they're going to actually manage the payments. So if we can move to the next slide, please, and to the next one. Thank you. So before I go onto the mappings, so like I said, it's a national standard. All system suppliers have now mandated and implemented a functionality so you can map your slot types. It works differently for each system supplier, but as a general principle, all you need to do is, for every slot type that you have, you get 3 columns. One is the service setting, one is the context type, and one is the category. So for the first column, the service setting, it's basically asking the question, where does that activity take place? Is it general practice, primary care, extended access, or other? And you just click on one of those. Then you kind of move on to the context type, and it asks you what it is. So is it a care-related encounter? A care-related encounter is just an appointment. A care-related activity is stuff that you're doing for the patient without the patient being present. And the third one is just admin and practice staff activities. And then once you've kind of done that, you kind of move into the final column, which is the category, and a list of 26 individual categories, but that gets filtered as you kind of go through the service setting and click the service setting, and as you go into a context type and select the appropriate context type. So you just get a filtered list of the categories that are relevant for that specific event. So next slide, please. So there's a lot of resources around to kind of help you do this. In terms of how you should approach the mapping. So there's some guidance around which shows you the national categories in a table. It gives a description of what the categories are. It gives an example of what the categories are, and it kind of helps you through that. So that a good starting point would be to review that guidance and the related guidance, which I'll give the links to a bit later. And the other thing that you really need to do is archive or delete any slot types. And that's been sort of really useful, and practice managers have found it's really useful, because what it enables you to do is do some bit of housekeeping. The practice managers will kind of know that, you know, there are lots of slot types. You know, some of them you use, some of them they've always been there and you don't use them, and some of them are there and you look at them and you don't know what they are. So it's a good opportunity for you to do some housekeeping, archive or delete slot types that you don't use, and then sort of start the mapping. Because what you don't want to do is, you know, try and map slot types that you just don't use. It's just going to waste your time. So, you know, archive or delete them and then kind of move on to the mapping. So in terms of the mapping, it probably take you between 30 to 60 minutes. 30 minutes is probably a more realistic timing. It does give you the opportunity where you can sort of start save and return later, so you don't have to do it all in one go. What practice managers have kind of fed back and said they found useful was having the guidance document with the national categories table, you know, loaded up onto a second screen or printed out, and as a way to kind of follow through and check as they're kind of doing the mapping. And, you know, within the national categories table, there are actually examples of the slot type mapping to the national categories, which will help you, and you get stuck. There's more examples at the end of the guidance document as well. So those things should help you. And if you need any further help, advice, or support, you know, get in touch with your local primary care team or email NHS England on that email address. Brilliant. And the next slide, please. And then the next one after that. Thank you. And these here are some of these sort of guidance documents and videos that are available for people to use. My suggestion would be to download the user guidance, read it, familiarize yourself with the national categories and the national categories tables that I was talking about, that would be really useful to you to kind of help you map. There are some technical guidance from EMIS and TPP, and within those guidance, there are sort of things you may be familiar with, and all it kind of does here is kind of remind you of doing certain things within your system that will help you improve your data quality. So it kind of talks about, better use of model appointments, how to manage DNAs, how to review bookable slots, appointment status, how to manage squeezing appointments and so forth. So it really kind of gives you opportunities to kind of look at your system and use some of the advice there to kind of improve your data quality. And if you do get stuck on the national mappings, then there are videos from Halbeck who kind of provide that to us, and you can just kind of watch a demo of them doing their mapping, and that will help you if you need that help. And then the next slide, please. And just to sort of finally, there are some further help if you need it. NHS England have a good website around improving GP appointments data, and it talks about various different things, not just the mappings, which I'm sure if you read it, you'll find it useful. The second one is around investment and impact. If you want to read about that, those kind of stuff, it's just there for you to kind of look and read. And obviously the final one is the contact to the NHS England email address. And that's it. Thank you.
Giyash, thank you so much. And all those resources I think are going to be really helpful. I've put on the chat that all of these slides and the recording and question answers are all going to be saved on the HLP website. So if you want any of those, we can, they'll all be available when we upload those. So thank you, that was really helpful. I'm sure there'll be some questions coming at the end, and we are running beautifully to time. So thank you all very much. We're now going to move on to points of contact and appointment types in general practice. And Minal Bakai is going to run this session. Minal is a GP in North West London. She is the GP and clinical director for the Digital First Primary Care with NHS EI, and was part of our task and finish group, which was incredibly helpful because she had the sort of day-to-day knowledge of a working GP, but also has done a huge amount of work about digital improvements in general practice, and not only brought her expertise to the task and finish group, but also a load of stuff she's written. So there's loads of resources which may not have Minal's name on, but they've got Minal's flavour, which are captured in both the guide and the manual. So I'm going to hand over to Minal.
Thank you, Sian. And if we could go to the first slide, please. So I'd just like to pick up on a point that was made earlier. So trying to change our ways of working while actually doing the day job is incredibly challenging. And I'm a medium-sized partner in a medium-sized practice. We don't have a data team or analytics expertise in-house. And so I think it's just helpful to make people aware that there is national funding through the Digital First Primary Care programme that's provided to systems, to ICSs, to fund a holistic transformation support offer. So it's not really just centred around the digital, it's much broader than that and covers a lot of the data work that Tom and Giyash have already discussed. And it's there to provide a personalised support, so really matched to practice needs on an ongoing iterative basis to really help practices and PCNs do this. So if you haven't had that support, I would encourage reaching out to your CCG leads or your system ICS digital leads to get some of that help to do this, because I agree it's really, really difficult otherwise. And so just building on what Tom was saying, one of the reasons how we set up our appointment system and measure what we do is it's so important, is that it can actually help us respond to patient need and doing the right work. And so matching available capacity to need is critical for an effective and equitable access system. And this is an audit that was done of over 10,000 patient contacts in London general practice. It was done pre-pandemic, but we know these challenges are long-standing and historic. And what the data tells us is that regardless of the modality of access, a large proportion of the need that presents to general practice does not require a GP to deal with it. In fact, it's likely to be better managed by another person, another service, or by the patient themselves if they've got access to the right information and a reasonable level of health literacy. And this audit found that about 40% on average of contacts do not need a GP, but it also found that between practices and even within a practice, we as clinicians don't always agree on what we would deem appropriate, so it's quite a subjective measure, and figures range from anything from 40% to 90% of requests. So I think it's helpful when you're doing the measuring to develop a shared understanding of the types of requests that could be potentially avoidable. And what this audit found was that unmet need was about 20%. So if you do the maths, you could start to see if you were moving around some of the need or demand, we could have a more equitable access system for those that need a GP. If we could move to the next slide, please. So this is these are figures taken from the same audit, and what it found was that these 30 to 50% of appointments were potentially movable, and they included work that pharmacy could handle, that could be dealt with through self-care, services outside of the practice, or were non-clinical problems. And what we also know is that about 20, and this audit showed that about 20% of GP time is spent on about 5% of our patients, so our super attenders. And interestingly, when they delved into that data further, these weren't the patients that you would necessarily expect. They weren't all your frail, elderly, very complex patients, vulnerable patients, but often they were people with complex social needs who were struggling, had poor life situations, and really we'd been using general practice as a sticking plaster solution to gaps in services for these people. And what they found, and what other multiple studies have found, is that as we make access harder, appointments generally become skewed to the frequent attenders. So closing the door or making the door harder to access doesn't necessarily solve our problems when it comes to getting the right work to the right to general practice. And so using data to identify patient needs can be really helpful to identify where there are gaps in service, what needs to be put in place to meet those needs, and then help to inform planning, service design and recruitment, particularly of the additional roles and how we train them to ensure that they're being used optimally across our practices. So if we could move to the next slide, please. Now, there is no single best access system. All systems include trade-offs between convenience, continuity, resource and equity. However, the better access systems are flexible and they're constantly refined, as Tom said, in response to data and to feedback, to staff feedback and to patient feedback. And the key complaint that we hear from patients about access is that our systems are inflexible. They are designed around the system rather than the patient. And the pandemic, I think, has clearly highlighted there is no one size fits all, and patient groups are not homogenous. Different patients value different ways of accessing their general practice depending on the circumstance. And so digital routes used alongside telephone and in-person routes can provide more inclusive access. And I'm sure we all have stories, particularly during the pandemic, of people that have chosen a digital routes, and often our assumptions may have been challenged by some of the people that have been using digital routes. But I've certainly found that there are certain patients that prefer to go online, not because they prefer digital, but actually because it helps meets their needs or their goals in a better way than previous ways of doing things, particularly full-time workers, carers, parents who have children with a learning disability, people with a physical disability, the list goes on. So, but what is really, really important is that regardless of the route of access, it's important that we're consistent. So however somebody accesses general practice, we're consistent with signposting and triage wherever possible. Now, we have to be pragmatic, and there will always be exceptions. There will also always be people that we just need to book in directly for a face-to-face appointment because they're vulnerable, and that's just it. But for the majority, this helps us prioritise needs This helps us prioritise care based on need, moving away from an undifferentiated model of first come, first serve, which wasn't equitable. And the purpose of triage here is to get the patient's needs met by the most appropriate person or service with the minimum amount of handoff. A model, and it's not necessarily this model, but a model that includes triage explicitly acknowledges that a large proportion of the demand that we get doesn't need a GP to deal with it, going back to the data and the audit findings. And it aims to help practices better meet that demand within their existing capacity. And I think we need to recognise that we don't have infinite capacity. So we will always have to work within the confines of the capacity that we do have, but we can optimise the use of that skill mix. We can also help optimise the use of self-serve services, so online prescription ordering, looking at your test results online, self-referral services, either that you can phone up or access online, and also, of course, a blend of appointment types, matching the appointment type to best meet the needs of that patient. And that includes face-to-face consultations, of course, when needed, but also telephone, video consultations. Some practices also provide video group clinics, text or online messaging for straightforward, quick queries, and of course a home visit wherever that is necessary. So the three critical steps are really asking patients what they need, signposting by the appropriate member of the team, and then clinical triage to decide on the right consultation modality and time frame. And key benefits that are emerging from this way of working from, the independent research that's being conducted is that practices feel like they're getting some control back. They feel like they've got ability to organise their working day, to sort and allocate patient requests to the right person, prioritise based on need, flexibility to spend more time with those that have complex needs. It's easier to have your team meetings, huddles, and foster team relationships. And also because you can set time aside, but also ability to work more flexibly around your home life, so remote working, and that's been really important. I think it's really important to emphasise before I move on that every practice is different and will tailor its model and its approach to its local patients, its practice needs, preferences, staff skills, confidence. But there are some universal themes, and Tom has mentioned some of these already. Demand is predictable, so try to align your points of access with your capacity demand work, because you could have a brilliantly designed system, but it will only work if you've got the capacity designed in to meet that need. So, tip for our practice, about a third of our demand came in on a Monday. So we had to redo all our rotas so that, we had a third of our capacity and the right capacity available on a Monday. We moved session times. We moved administrative staff to work on, certain types of demand or certain routes, so the telephone or online access routes at particular times of day when we knew they were always going to be busy, and to avoid blocking out specific slots of activity for planned care or for meetings during high periods of demand or high predicted demand. Also look for bottlenecks and constraints, so avoid having fixed times only phone between 8 and 10 a.m. because that creates pressure points. And it's really, really important that all staff, all members of staff, particularly front of house, understand the roles of the wider team, what local services are available, and therefore can be trained in signposting. And then look critically at avoidable contacts, and then consider a system for tailoring the management of our patients that present very frequently. I think the other thing is when you're designing your system, it's really important to have a mechanism to identify patients that would benefit from either episodic continuity or continuity of care and build that in. And consider projects that involve local volunteers, your social prescribers, train them up as digital champions. There are free online courses like Learn My Way that are available and can help other members of your staff support some of them more digitally disadvantaged patients. And of course, communication. And one of the things that's not really happened partly due to the pandemic is that we've not been able to communicate with our patients as much as we'd like to about the various ways that they can access care. And in this new world, we have changed the narrative for patients, changed the concept of access for general practice from I need an appointment with my GP to tell us about your problem and we'll help you get care from the right person. This is not a simple message, and so nationally there is work with National Voices, Health Watch, other patient partners, patients to develop and test these messages, and then being able to. This is a great topic to be able to then take some comms and test them with your local patient groups and adapt. If we could move on to the next slide, please. So digital is an enabler. It is not a magic bullet, and many London general practices have employed digital services rapidly, particularly online consultation systems, messaging systems like AcuRx and video consultations to support triage and remote consultations. And these are huge achievements done at great pace. But which now need to be augmented. And we need to ensure that digital transformation really connects with the purpose and values of practice teams, and the whole team is clear about the vision and the problem that's trying to be solved. We don't want to digitise the patient interaction. We actually want to better match urgency and need to clinical capacity, and that includes continuity. We don't want to force patients to go online. We want to see demand more clearly, allocate resource better, help patients interact in a way that suits them better, and we want to improve coordination and collaboration. And this is a journey to develop each of these, but there are some great examples across London. We're seeing virtual hubs being developed where PCNs are using shared workforce and capacity to support with management of online consultation requests. There is a pilot to integrate online consultations with community pharmacy to redirect minor ailment queries automatically to the right place. If we could move on to the next slide, please. So this is really just a case example, and I'll be relatively brief because I can see Sian's popped up, so I think I'm probably talking too much. But I think this is just about not assuming who does and does not want to use digital, that it can work for lots of people. And although we hear a lot of anecdotes about it being used for minor issues that don't need general practice, there are also some very significant issues that people are using it for. For example, Alison, a patient who has breast cancer, unfortunately, but was too scared to access the practice by phone, didn't want to come in. She found an online access route, online consultation system was really helpful for her to make contact. She had a face-to-face appointment the same day. She was diagnosed quickly, and she now uses remote methods of interacting with her practice to maintain follow-up with her practice team, which is really great. And if we could move on to the next slide. I think this is just to reiterate that although we hear all of the negativity in the media and lots of anecdotes about general practice, actually the data tells us a different story, and I think we mustn't forget that. This is a huge survey, 850,000 responses from patients that found that overall satisfaction with general practice is improved, satisfaction with making an appointment is improved, satisfaction with appointment times is improved. We are doing lots and lots of things right despite being in the middle of a pandemic, and so it's about building on that and just remembering to look at the data. If we could go to the next slide, please. So this is just some practical pointers on deciding about the right appointment type. So there is no best appointment type, and actually deciding on the right appointment type for the patient that's sitting in front of you is a skill. It's impossible to generalise, but there are some principles here that can be applied when used in the right context. And you know, the key thing is that in addition to the reason for the consultation, it's important to identify contextual factors, things like people's access needs, privacy needs, their digital setup at home, and also being mindful that you can change the consultation modality. So if you are uncertain, be flexible and change. And peer review and learning is going to be key to this. So just within your practice team, and we do this within our practice, we look at our outcome data and we look at where there is variation between clinicians, and we challenge each other and we share learning and we discuss why we manage certain cases in certain ways. And that's really helped us build confidence amongst our practice team about how we make decisions about the most appropriate consultation type. And then the last slide, I think. Finally, there's been lots of work done by Healthwatch and National Voices around the patient feedback and what can we learn from patients about how we can improve access for them. And key things are to identify their access and communication needs during triage, working closely with their carers or their advocates, providing translation services, having clarity in our communications to set expectations, a clear contact time frame, for example, is appreciated. But what we know that can be challenging with practices when we're working on in a triage way. And so what some practices have found helpful is sending an SMS 15 minutes before they plan to call the patient, so that gives them time to find a private, quiet place to take the call. Don't ask patients for information you already have. If they've provided an online consultation, then summarise, but don't necessarily ask them all the same questions. Again, proactively check what the patient needs and clarify what's going to happen next and who's responsible for the next stages of care. So they've got a very clear plan in their head of what happens next. And feedback, seek feedback about people's experiences is really, really important, because that's how we learn. I'll stop there because there's a lot in this.
Minal, thank you. That was really, really good. And there's lots of bits of that we're going to pick up in future webinars as well, particularly on patient experience, patients who attend frequently. But I'm getting this theme of data from everybody today. This is a very data-focused, data and flexibility are the two things I'm hearing. We've got one final and short presentation from Tom about the tricky issue of managing patients who don't attend or failed encounters. Tom, thank you.
Thanks, Sean. And I'm probably going to say things like data and flexibility again. So just to note that, can I get the next slide, Lee, please? I'll try and keep it pretty brief. I know we're against the clock. Just really, the main thing to say about DNAs, no-shows, or in fact failed encounters as well, is that they are a reliable outcome of whatever system it is that you're using. So this guy pictured here is William Edward Deming, who's the sort of father of quality improvement and understanding variation in lots of different settings, including healthcare. And his quote of "every system is perfectly designed to get the results it gets." That may have been misattributed to him, but he said something similar. And I spent loads of time working with teams to try and reduce DNAs. And if I could save anybody on this call any time at all, it's just stop wasting time with efforts to remind, cajole people or enforce policies around DNAs. That's not going to make that much difference, and it's certainly not going to make a difference for a long time. And I think one of the issues we've got around DNAs is that they I think really unfortunately drive potentially a lot of sort of inequalities of access because of the way that our systems are set up, and the fact that there's potentially appointment capacity there that's not being used or being used in the wrong way. So we did we looked at some data, and we looked at data from over 4 million appointments in Tower Hamlets over a period of years, and we controlled them for sort of patient demographics and all that kind of stuff, and basically found that the principal driver for people not showing up to appointments is the length of time in advance that they're booked. So sort of 3/4 of DNAs occur when the time between booking and attending an appointment is more than 1 day, and that for me, and practices that change their appointment booking time radically changed their DNA rates, and it stayed like that for a long period of time. So essentially the summary here is: don't waste your time cajoling, persuading, punishing people. look at your appointment system, because that's the thing that's driving your no-shows. And I think now that most people on the phone, you'll have, and doing triage, you'll have noticed your DNA rates have dropped through the roof, through the floor anyway. But so I think the bellwether of the health of your triage call and recall system will be the number of failed encounters that you get. So failed encounters are absolutely correlated from the length of time it takes you to get back in touch with people. The longer it takes, the more failed encounters you're going to get. So again, that's a system thing. Your system is reliably giving you those results. So if you want to reduce failed encounters, you want to have a look at the way that you're planning your callbacks, and that's where we come back to the point about flexibility. If we can get the next slide, please, Lee. So think about the system, think about flexibility, think about consulting with people who are using you're trying to access your system, because they'll help you guide you in the way that it's going to work best for them. If a system that tends to work better for patients works better for practices usually. And I think I can't say anything about DNAs and no-shows without sort of flagging. Obviously, there are particular situations around no-shows and DNAs which should be flags to be cautious about, people who for whom you might have safeguarding concerns. So I'm sure almost everybody on this call will be aware of the child not brought for the appointment codes that you can use for children. But thinking about folks who are children not brought to appointments, or vulnerable adults who are not brought to appointments, or things like scheduled immunisations, that's a big flag. So everything I've said about trying to reduce DNAs is true, but we've also got to have this in our mind that DNAs can be a sign of something else that we need to look at more carefully. And I think, just to say, where we've tried to approach reducing DNAs as a single kind of fix for an appointment system, we've tended to not do very well with it. So DNAs need to be considered as part of the whole system of access. So they're in some way a kind of measure of the health of your access system. So it's one of I think a really good example when we look at this piece of work around access, that it's multifactorial. It's about looking at the whole system. Because some of the answers to DNAs will probably be in in engaging with people and testing out changes and looking at your data and measuring things. So it's part of a system. It's a system issue. So the solution tends to be a system approach. Sian.
Thank you very much indeed. That was great. Can I ask all the speakers to please unmute and uncamera? And then we are going to get David, who has been scribbling away with questions that have been submitted before, to put everyone on their toes. And we've got, we said we'd go on till 6:20. This is a slightly longer webinar today. The other ones will just be an hour, but we've just got sort of 10 minutes to take some of those questions and see what we can respond to. So David, if you're there, I don't know if you want to ping something to somebody.
That's all right. I thought we'd start. We haven't had many questions in the chat. We have got one which I'll pick up in a second. We did, as part of the registration process, ask for people to submit questions, which we've got a few. So I'll bring up those. But before I do, obviously we've got the first one around patient comms, and I think it's a point around the need to sort of change the patient culture, because obviously there's an expectation around face-to-face, even when it's not necessarily clinically appropriate. I suppose that perhaps everyone would agree on that, but it's perhaps just a point to note.
Yeah, I mean, Minal made this point quite well of sharing the data, and I think it's really easy to focus on the negative and focus on the negative experience of patients. And this, again, I know we keep going on about data, but if you go and look at your GP patient survey data and see how many patients are actually happy with the care that you give. We're going to talk about this a bit more in the next webinar when we're talking about engaging with patients, patient expectations, patient experience. We are having a hard time, I think, at the moment in general practice. I think there's a lot of negative stuff in the press. I think patients pick up on that. You hear it in the waiting room, you hear it in the supermarket. But I would just say go back and look at your GP survey data, because actually it will probably make you feel much better, rather than comments on NHS or whatever. Because if you look at the data, I think more people are happy with your care. And I kind of give the comparison of a really busy day when you've had lots of contacts, and the vast majority of those contacts are positive, with patients saying thank you, and you come up with a shared solution and it all works well. But you don't take those 39 positive contacts home with you. You take the one who was difficult, who upset you, who was maybe rude to reception. And I think we're slightly, our minds can sometimes be over-focused on the negative. So yes, I absolutely agree. Then it is a challenging situation at the moment. And I think and Tom, do you want to jump in there? But I think that the press isn't helping. But look at your GP survey and look at the stuff that Minal shared, because actually most people are pretty happy with this. Tom, did you want to add to that?
Yeah, I think just to say that basically think about what more change has happened in general practice in the last 18 months than has happened in the last 18 years. And I think if you speak to any surgery that changes its mode of access, so back in the day when my surgery changed to a triage model, you saw a spike in complaints, and then people got used to this, and then complaints just disappeared because the satisfaction with the new system improved. And I think the risk in the system at the moment is there's a lot of change. It's been implemented in a hurry without any consultation, just because of the pandemic. And what we're seeing now is a reaction to that, which is it's a kind of normal thing. And I think we almost need to not overreact to the reaction back, because it will kind of settle itself out. But I think there is something here about the sort of culture of triage, because triage should be about getting the person to the right, who expresses a need, to the right personal service or self-management options, with the least amount of handoff and faff. And I think if it's approached in a way of like as a barrier to getting face-to-face, it's bonkers, and we're just wasting everybody's time, wasting our time, wasting people's time. And actually a really nuanced triage process is very good at getting people to the thing that they need as smoothly as possible, without over processing people and making people tell the story twice or have to battle for something. That's not good for anybody. So yeah, I think but I think the kind of pendulums are, swung very hard in one direction, and the system will kind of find its own way. But I think we have to acknowledge that you're bound to get some pushback from that, but also own the fact that we need to have our systems in a way that they're doing what they should be doing, rather than putting up unnecessary barriers.
Thanks. It leads to another question that we had around the proportion of appointments that should be face-to-face, telephone, and online. And is there any value in trying to set targets for that? And I'll put Minal on the spot for that one, if you don't mind.
Yeah, no, so I feel quite strongly about that. So absolutely not. It is all about moving to a more personalised approach. So I don't think, some days in clinic I might see 60% of my patients face to face, and then another day in clinic it might be 30%. It just depends on who's there and what they're presenting with and why. So I think it's about, again, as we do in clinical practice, we have principles that we apply. We think about the context, we think about the person in front of us who's presenting, and then use the best approach to meet that person's needs. I think where data can be really helpful, though, is what I talked about before, variation. So understanding within your practice, what are the different outcomes between different clinicians, and what can we learn from each other to have a more standardised, consistent approach for our patients, and actually all improve how we deliver clinical care. And that is true of regardless of the modality, actually. So I think it's more about the continuous quality improvement, learning approach, but no targets.
Thanks, Minal. David, what else have you got to throw at us?
Well, I'll pop back to capacity and demand to follow the theme of the start of the webinar. Tom, do you have a steer on how many appointments a practice should be offering a week?
I think I think it depending on the season, and you probably look, if I was to pull a figure that probably is reasonable, it's sort of between 70 and 100 contacts per 1,000 patients per week, and that's quite a broad range. So it really does, it depends on lots of factors, not least what Minal was just mentioning there, because different people operate in different ways. What I would say is the only way to find out what you need is by having a triage system or a system by which you can both capture express needs, so your booked appointments, and also unmet need. And that, you've got to have a way of looking at that, because then you'll know how much you should be offering. And then once you've done that, you can start to think about what's avoidable within that work. But I think everybody's practice is different, but I've found that range is probably about right. But that is quite a big range, as you'll notice.
Can I check with you, Tom? When you say 70 to 100, you're not talking whole team appointments. You're talking about GP appointments, presumably nurse. Yeah.
This is
when it gets tricky as well. How many pharmacy appointments? How many nurse appointments? How many GP appointments? How much you do on the telephone? So I think you're right. It's good to have a ballpark, but you have to recognise that you've got to flex to who your team is, and what your modalities are.
So we would define that as reactive demand. So this is the work, kind of inbound work, Sian, almost by sort of regardless of who's doing it. But what I would say is that there's things there about making every contact count, you know, because we've got people who are part of a planned care system and a reactive care system. We want to make sure that you're getting the most out of every contact. And I think there is there's something around, God, my brain's gone completely blank, thankfully. There is, no, it's all right. It'll come to me.
We'll let Giyash, who's obviously got something active in his brain, to speak then.
Yeah, I mean, there is something around the CCGs who set out targets for how many patients you should be seeing. I think it's sort of around what's almost saying 70 to 100 patients per 1,000. But again, there's this other issue around, you know, like you kind of talked about, you know, which resources are available to provide appointments, but also each practice is different, and practice patient list size are hugely variable as well. So you sort of need to kind of work out yourself in a sense based on that. There's practice to have 10,000 patients, there's practice to have 3,000 patients. So, you know, you just need to sort of make a decision.
And stop not talking about, I think contacts, always remember the kind of, the two things you really want to know about is the time you've got. I think if we think about appointments, we're already in a kind of mental box about what that means. It's a contact. And an appointment in our minds, it feels like an aliquot of 10 minutes, and that's I think a bit of a restrictive thing when we're trying to think creatively about access. So I think that, you know, stop using the word appointment, think about contacts, because that's when you start to open up and think about what you might use that time creatively to do.
Thank you. I'm going to draw it to a close now because we're 1 minute off our finish time. That's been really helpful. You can see from the conversation that's how the task and finish group went, and that's how we kind of got to where we got to, with lots of discussion. So thank you for everybody for joining today. My take-home messages are really that it's about a flexible offer that suits your patients and your teams, that you use data to help inform what you do. And then, so those are the two real top take homes for me. Next week we're talking about engaging with patients, and we will be talking about expectations and patient experience. We'll be talking about inequalities, and we'll be doing a particular session on those patients who attend very frequently and thinking about practice approaches to that. So please do join us. If you go onto the HLP website, you will be able to, you have to sign up for each webinar separately. Please do spread the word, and thank you to all our speakers this evening and to all the people who've attended. I'm sure you're all ready to go enjoy your evening. So thank you all very much indeed.
Okay, thanks everyone. Bye-bye.